Hi, everyone.
Hey, how are you?
How are you? Good evening. How are you doing?
Good, good. Glad to be here.
Welcome.
Um,
So I'm going to introduce Dr. Avram, but I really just want to thank everyone for tuning in tonight. I want to thank our social media ambassadors, our social media committee, and really Liz, Katie, and Jamie Wiley, who have been working behind the scenes to make this happen. So without further ado, we are so excited tonight to introduce our inaugural session, and who better than our president of the ASDS, Dr. Mathew Avram. Our format this evening is going to be Dr. Avram is going to deliver an outstanding lecture to you guys. We're going to keep that about 10 to 15 minutes, and then we're going to answer all your questions on aging from your true skin experts. So with that, Dr. Avram, looking forward to your lecture.
okay, great. So I'm very excited to be part of this inaugural lecture. I have my wife, Allison, filming for me. I'm doing a little selfie angle to start with. The whole idea behind this is it's going to be physicians, it's going to be patients. So I'm going to try and keep the lecture to make it interesting to everyone involved. So I'm going to go to the aging face. That's the topic. I'm going to spin the camera around here. All right, there's Allison. Let me get started. So there are lots of issues when we look at the aging face. And this is actually someone that I used when I was in the iron competition, iron surgeon competition a few years ago. In this patient, we have pan-facial volume loss, rhytids, both static and dynamic, dyschromia, texture, tone, festoons, and laxity. So there are many cosmetic issues here, and the goal is to achieve as much benefit as possible without surgery. Laser and energy-based devices alone will provide, at best, partial improvement. We need to provide volumization and softening of her dynamic rhytids and other issues that can't be done with laser alone. So the way we approach the aging face is you need to treat from the deep to the superficial, from the periosteum to the epidermis. We want to volumize her skeletal appearance, smoothen her lines, clean up her pigment, soften her festoons, and tighten her skin, all without the use of a scalpel. And that's what we like to do at the ASDS, is give a refreshed look. And to understand the aging face, we can see the outside, but what we really need to understand, it's what's underneath it. So what do we have here? We have loss of fat, that's fat atrophy. We have elastic tissue loosening, so that's what's causing kind of the sagging of the skin, and which causes a skeletalization, and that's causing many of the lines, such as here, these lines that they call parentheses or nasolabial folds and the marionette lines. So, and there's also changes in the bony structure and soft tissue structure as well. So you're losing volume, and you're losing the framework and structure of the face, and you need to recreate it. And that's what's happening deep. More superficially, you want to help with texture, tone, pigment, telangiectasias. So you need a multimodal approach looking at different issues. You want to start with volume. You can use hyaluronic acid fillers, PLLA, calcium hydroxylapatite. Then you can go to dynamic rhytids. This is injecting into muscles. This is neurotoxins. Then you have static rhytids, and you can do lasers for that. You want to exercise caution in skin of color, but you can certainly treat, and you can do fillers as well. Dyschromia, texture, and tone, again, lasers, energy-based devices with caution for some of the indications in skin of color, and chemical peels as well. And then for jowls, laxity, you can do tissue tightening devices such as fractional ultrasound, radio frequency, and mid-infrared devices, and these are safe in all skin types. So that's kind of a framework of everything. Now I'm going to go a little bit step by step, very briefly, to give an overview just to get the conversation started. So we'll talk about soft tissue fillers first. This is volumetric filling to replace deep facial fat loss in the following areas. You can see the temples, the mid-face, the mandibular area, the preauricular area, the cutaneous lips, and chin. Again, this is what I talked about. There's a loss of soft tissue, there's a loss of fat, and there's a change in bony structure. And you can use fillers for all of these different indications that I have listed here. So one way that you can help with this is using a cannula. And a cannula is basically creating a port and then using a long, thin tube that looks a lot like a long needle And by creating a port, in other words, putting in a little injection or a little poke in this area here, you have a portal of entry. And then what you can do is you can use this cannula to go into the areas. And again, I'm not going to get into technique tonight at all, just to explain that what you're doing is you have a little spigot at the end, and you can go into these different areas and treat. What I'm trying to do here is to create volumization. The advantage of the cannula is there tends to be a little bit less bruising. There is maybe a slightly decreased risk for vascular occlusion. I'll talk about that a little bit as well. And you can just see me doing it in different areas. But you can see even when I inject in the preauricular area, you'll see me withdraw to make sure that I'm not in a vessel. That never tells you 100% you're not in a vessel, but it's just a safety measure. And then finally, even with lip lines, just by creating a little volumization everywhere, you can have those lines effaced a little bit by creating some volume and therefore getting a little bit of reflection and fewer lines. The nice thing about doing here, I did, multiple is there's just a hint of bruising. And I know it's hard to see over Instagram filming off a screen, but not much. Here she is 1 week later. She's more volumized, lighting slightly different, but you get the idea. Not much downtime. She looks like the same person, just more refreshed. Maybe, looks a little bit less tired and has some better volume. Now this, I just want to show this because one thing that we need to be very careful of is anyone that you do filler in, you have the possibility of getting a vascular occlusion, injecting into a vessel. So you need to recognize clinically, this can happen in different ways. This is a very classic appearance of retiform purpura outside the area of injection. That is a dermatologic emergency where you need to use hyaluronic acid and other interventions to improve it. Now, toxins, these are neurotoxins. These are the things that soften lines. So I'm going to show you mine because I've got really strong ones because I don't use them. Here's the famous 11s, the glabellar furrows. Here you can see my forehead, very deep lines. These are caused not so much by all the sun I had over the years. They're caused by the fact that my muscles have full movement. But if we relax those muscles and we decrease the movement, we have the lines are less noticeable. And it's better to do that when you're younger. I'm beyond that point because it actually prevents lines as we age. So let's take a look. She's got dynamic rhytids in the glabella area. That's where the 11s are, around the eyes, upper forehead, and cutaneous lip. And you really here just, you need to know your basic anatomy in terms of where to inject into the muscles and the appropriate amount to inject to understand how to get the best before and after. This is just an example of that. One thing, since I'm going to talk about combination treatments, is I don't like to use botulinum toxins as the same day that you're doing a fractional laser due to swelling that can cause migration of the Botox into areas that you don't want it. There are so many different areas we can treat cosmetically for Botox in medical areas. Actually, medical indications for, for botulinum toxins are manifold. There are 4 brands. There is Evolis, there's Botox, there's Jeuveau, and there's Xeomin. I want to be fair to all the companies since I mentioned one of them. Okay, static rhytids. These are rhytids, and I got these too, where the lines are there whether you're moving them or not. And I have them around my eyes, and you can see some fixed in my forehead as well. Here you want to choose more energy-based devices according to the pathology that you're treating, and you can also do fillers as well. There are a bunch of different fractional devices that were developed right here where I am at Massachusetts General Hospital. There's non-ablative fractional 1927 nanometer laser. There's a hybrid fractional laser, which is ablative and non-ablative. And there's ablative fractional lasers such as carbon dioxide and erbium fractional ablative lasers. One thing I want to point out is fractional radio frequency is the one that best avoids the dermal epidermal junction. So in skin of color, if you have a fractional radio frequency device with microneedling, you can insulate the tip so that the energy is only placed more deeply. So you bypass the dermal epidermal junction. That's where the pigment is, and that's where you're going to get the hyperpigmentation issues. So with these devices, you can bypass that completely. And I will say that you can use all these devices in all skin types, but you need to be very, very careful in doing so. So these are different fractional patterns of remodeling. You get columns of thermal damage. This is heating. This is non-ablative fractional. The mid-infrared devices, here's the 1927. You get this heating more superficially. And then ablative fractional resurfacing, you're actually drilling holes into skin. It's being vaporized. The skin is actually within a short period of time being not coagulated, it's being vaporized. So, and this is, I always like to show histology. This is ablative fractional lasers. This is Chris Zachary's group. And you can see these channels being drilled into the skin with areas. It's hard to see, I know, with the film, but you can see these purple areas. Those are coagulated areas. Those are areas that have been heated and denaturized. So ablative fractional resurfacing, you get more significant results with one treatment than the non-ablative. It's better for the deeper lines that you get around the mouth and around the eyes. And it also helps texture, tone, and dyschromia. This is an example of an ablative fractional resurfacing device. You can see those white little spots there. Those are actually zones of ablation in the skin that you're seeing as you watch. And here's pre-op and post-op. You can see immediately afterwards swelling, pinpoint bleeding. The reason you get bleeding is when you ablate through these channels, you break open blood vessels and they just extrude right out of the skin and show as bleeding. The nice thing about that is it can help treat some of those broken blood vessels. And here's the results 3 months later. It might be a little hard to pick up over the Instagram feed, but you can see some tightening, some texture and tone improvement, some improvement in wrinkles and dermatoheliosis. You know, it's pretty good. It's like a double, maybe a triple. But what I like is we treated around the eyes here, and you can see some nice improvement of the festoons. Festoons are kind of this area where you get this puffing out of skin. You can see the periorbital lines are smoother, and you can see, most importantly, a little bit of lid retraction. So the eyelid actually lifted. This is 3 months out. This is not a post-op treatment. This is a real result, and that's a nice result. But here's the caution, and this is why you need to see an ASDS board-certified dermatologic expert. Used in unskilled hands, you can get horrific scarring with ablative fractional laser, particularly if you do the passes too quickly. You need to allow the skin to heal, and when you get off the face, you need to lower your densities, because with higher densities and with not enough time to allow for cooling, you can create too much heat injury at once, and you will get this horrific scarring. Now, I think this is very important. This is looking at treating skin types 4 through 6. Again, you can use these lasers in all skin types, provided you are careful in how you do it. This is really important. What I have here, there are 4 different areas that have been treated on the skin type of a skin type 5 patient. And what I have is, when you go deep, but you do low density, there is very little hyperpigmentation. This is about a week or 2 later. But when you increase, here we increase the density, and here it's the most superficial and the most dense, there's far more hyperpigmentation. So the take-home principle here is not how deeply you go, but it's the density of the treatment. This is very high density here, and what you can see is clear hyperpigmentation. So what you need to do in as you get into skin types 3, 4, 5, and 6 is watch, especially 4, 5, and 6, watch the density of your treatments. The more dense the treatments are, the more likely you are to get hyperpigmentation and, in that case, problems in terms of healing and results. So dyschromia, texture, and tone. So we started with skeletalization with fillers. We moved to toxins for musculature. And then we kind of got to static rhytids. Now we're kind of more on the surface of the skin. I find, and there are different devices you can use, that 1927 nanometer fractional thulium lasers are effective for this. They are designed to treat superficial skin conditions. They are very strongly taken up by water, so they don't penetrate very deeply in the skin. When you get to 1550 nanometers, there's less strong absorption, so there's more penetration more deeply into the skin, so you can treat things like acne scars. With the 1927, it doesn't go very deep because it's just the laser is absorbed very well at that wavelength. So this is perfect with people with dermatoheliosis, texture and tone issues, particularly in skin types 1 through 3. But again, with low densities, you can safely treat skin types 5 and 6. Again, you need to be very careful. Use lower energies, and maybe use one of the devices that that are designed for these lower density treatments. Now, I just want to go over the concept of fractional here as I'm treating this patient. These are hundreds of thousands of microscopic pulses, thermally coagulating 30 to 40% of the skin. That means 30 to 40% of the skin is being treated within the 10 minutes of this treatment that I'm doing, up to 200 microns. But what's amazing is the 60% of the skin that is not treated is fully healing this with no scarring, with no injury, actually no perceptible injury in the skin, and actual rejuvenation. It's actually scientifically remarkable. This is a before and after. All that was treated here was dermatoheliosis. And you can use a picosecond laser, a nanosecond laser, or an IPL or a broadband light to treat individual antigenes at the time of treatment with the fractional laser. Now, you can combine fractional lasers, pulse dye lasers, and pigment lasers at the same session. And what you do is that the order actually matters. You start with a vascular laser first, a pulse dye laser, a KTP laser, or an IPL. Then you treat the pigment, and then you do the fractional treatment itself. And by doing that, you get more extensive improvement. Now, this is a patient who is a student from China who has red acne scars. So you can see the yellow flash, that's 95 nanometers, that's a pulse dye laser. I'm treating her scar erythema. And then immediately I go into a fractional laser resurfacing. That way you can treat the scar erythema and the texture of the scar as well. And that's a powerful combination with the same amount of downtime. And here I'm actually using 3 different fractional lasers on one patient. I'm using fractional ablative CO2 on the cutaneous lip where the deepest lines are. I'm treating with a 1927 nanometer laser on the forehead where we get a lot of dermatoheliosis, then 1550 on the cheeks. So the final thing I'm going to talk about, we just have a few slides left, is fractional ultrasound in this case, but the idea here is tissue tightening. Now, fractional ultrasound was in part developed by my colleague, Rox Sanderson, here at Mass General, and this allows, ultrasound is interesting because it could go to any depth if you use ultrasound technology, but for this one, it's going to the SMAS, and then the dermis, and more superficially in the dermis. And what you do is you can get very deep treatments with these pulses of energy. Imaging guides the treatment, and this is safe in all skin types, and you see the results in 3 to 6 months. That's true with all the tissue tightening devices, whether it's ultrasound, radio frequency, or some of the mid-infrared ones. These tend not to be a concern for patients with more pigments in their skin. So you have this focused ultrasound, there's ultrasound imaging, and there's actually ultrasound pulses that go into the skin that you can see as you're doing the treatments. And this is a patient before and after. Again, the device doesn't matter as much as just the idea of tightening. I could only show one device, so I decided to show that one. So to conclude, when you approach the aging face, you want to go from deep to superficial, and you need to understand anatomy. You need to understand skin physiology. You need to understand what you're targeting in the skin to do it.
Maybe you were on one slide before and then it went blank, but I can see you, I can hear you now.
Okay, sorry about that. Looks like a lot of the audience is coming back too. Sorry, everyone. My apologies.
Thank you for joining us again. So no, it's been great talk so far. I'm excited to hear the rest.
Great. Oh, no. That was the I believe that was the end. So we can talk about this, and it said, yeah, you need to know your anatomy. Thank you, Morgan. So yeah, basically the only slide was a nice picture of my kids. So we finished, luckily. So I mean, we can go over questions. I know that you wanted to discuss some things, so why don't we start with that, and then if people have questions, please ask, and we can go through them.
Present. So I know we talk a lot when we're on podium, we're doing live demonstrations. You know, we have everything at our disposal. So it's a little bit different, the actual clinic, when we have a patient that's coming in versus when we're teaching or demonstrating. So I wanted to show you guys, and I kind of wanted to talk over with Dr. Avram, and I would love it if our audience participates as well or asks questions. So I live in Dallas, Texas, and we have some beautiful people that walk through the doors. And how would you treat this patient? So I'm going to put this up. And I'm sorry if there's a glare. Hopefully you all can see this. Is this coming through okay? So it's a patient. She's in her, I want to say mid-50s. I mean, stunning patient. This is her side view. I will point out her temples are a little bit hollow, but I mean, she has beautiful skin, a little bit of hyperpigmentation. A little bit of actinic damage as well. She's a former model from Miami that now walks through my doors. So let me show you another view of her. And I would love to hear approach, and then I'm going to share mine as well. So Dr. Avram, this beautiful lady walks through your doors, a little bit of pigment, some volume loss, mid 50s, otherwise, great candidate. So how would you start off?
Well, the first thing I would do is ask her why she's coming to see me. So I would say, listen, what brings you here today? And I'd want to hear what bothers her because, we're in a field of medicine that's very different from others. We treat patients because there's something that bothers them. So if someone has a melanoma, I'll say we need to take that out. But if someone looks at their face and there's a particular issue that bothers them, that's what I would address. So I'd want to know what she's coming in for. If she says, listen, I have a little bit of pigment on my face. I'd like to see if there's anything you can do. Number one, you have to check to see if there's anything that's atypical or something that may, again, medical first. Is there a skin cancer or any issue like that? The other thing I would do, especially as we're getting into this time of the year, especially if I were down in Texas, I would look to see if there's any indication of melasma. If you start treating patients with pigment lasers and you start getting into spring where there's more sun, particularly in a place like Dallas, or if you're down in Southern California or Miami, but most of the country, you can get yourself into trouble if you don't recognize subtle clinical melasma because you treat the patient and they get a little bit better. Then they go into the sun, 4-6 weeks later, and then their melasma flares up. And I guarantee you the patient's going to say that it was your laser that caused it, whereas what it really was is just their melasma was flaring up. So I'd look for melasma. If there is some background dermatoheliosis, I would think about, we have various 1927 nanometer lasers we could use. You could use a more aggressive one, a less aggressive one. You could use IPL, broadband light. There are lots of different names for these flash lamps that use broadband light to improve the skin. And if they're telangiectasias, Paul Friedman, I'll do a shout out since we're talking about Texas, has done some great work to show that pulse dye lasers even help. So if there's some background that can help as well, if there is indeed some melasma, you can try chemical peels as well. And then I would talk about sunscreen, sunblock, all of those things to help the outcome over time and retinoids. In terms of volume issues, I didn't get a great look at her from the picture, but a nice thing to do is to sometimes put a little bit of filler up in the zygoma area to get a little bit of lift and maybe get a little bit of volumization as well. And that picks up again, there's some patients online. These lines here, they're called nasolabial folds. These are also called parentheses more colloquially, and you could do that as well. So and then if the other thing you can do is tissue tightening, and I mentioned some of the devices. They're radio frequency devices, they're ultrasound devices. I think what's important is to message to the patient appropriately that these devices are not a facelift, they're not close to a facelift. They get you part of the way there. So I always show them like a diagram, like if this is where you are now and this is where a facelift, but I go much farther than that. I say these devices will get you to about here. If you do nothing, you're going to go off the screen because you're going to continue to worsen. If you do a tissue tightening device, you'll get a little bit better and you may prevent aging that happens over time. So those would be some of the things I think about. And I'd be very curious to get your thoughts as well.
I absolutely agree. So anytime, no matter what the patient is coming in for, whether it's acne, melasma, hair loss, injectables, my first question is, what brought you in today? Why now? Do you have something coming up? That tells me a lot of things. I'll know if they're preparing for a happy event, if they're getting ready for a wedding or some sort of event, or if they have a sad event, if they've, lost someone or had a divorce or other things. That kind of tells me where they are, maybe what their motivations are, and it helps me to establish a game plan. I always ask, well, not with COVID, it doesn't matter that much anymore, but I would always ask about events previously if they had, something at work or something in their social life. COVID has been great. A lot of people have downtimes, they can wear their masks, no one kind of knows. So that's my first step. I agree with you. I always share that the skin is the canvas. We're dermatologists. I want to, we have all these wonderful tools in our toolbox, but the skin really is that. I want to give you healthy skin. We see tons of melasma, and everyone comes in. I don't know where they've heard about this. I guess it's some sort of carboxy laser. There's laser toning that many of our colleagues do overseas. But my first line, honestly, is topical therapy. Really good combination topical therapy for melasma or any pigmentary issue. And you will be seeing me frequently because melasma comes back with any sun exposure, and your sunscreen is critical. If you're not going to do the sunscreen, we're finished. Then my next step really is I start from the outside and I work in, because as we know, over time, bone reabsorbs. As the bone reabsorbs, especially in the maxilla and the mandible, the ligaments, the underlying fat pads and tissue are also reabsorbing. And all those fat pads, I have a nice diagram. It's hard here. I'll show the slide. When you look at the fat pads, it's quite telling, and I'll try to pull it up. I actually like to show this image because each one is individual. And when you have a loss of the fat pads, that's going to affect the whole dynamic of the face. And I think when you show that, patients and other physicians will really understand, sorry, that this is one of my favorite images. I don't know if it's coming across with this glare, but you can see the individual fat pads. And remember, when you lose these, you lose your underlying architecture. And so when I'm putting in filler, I'm not going right here and putting two globs. That's one of the things that I can tell an inexperienced injector. They don't know the anatomy and they're not working on the frame. So I start out and then I work in. And just as a word of advice, again, with COVID, it's changed my protocol a little bit. But previously, I don't like, especially if it's a new patient, to do a lot of procedures at one time. I like to stage everything and bring people back in about 2 to 4 weeks when all the swelling is gone. We take photographs. I think you get the best results that way. Some of the areas that I love are temples. Again, just like you, outer lateral zygoma, chin and jawline, kind of making the frame. When you make a beautiful frame, there's not a lot I have to do in this region. And then it comes down to maintenance, and I call them tweakments. They come in over time and we work together. So that's kind of my approach, and I think less is more. I really love to explain to patients why I don't do certain things, and that's something now with time that I've learned. I remember, if I can share anything, if there are any residents that are here, take photographs always. Always. Patients forget what they look like. You may forget. But when you have good photographs and you can show them their progress, it's very, very helpful. Don't do anything you're not comfortable doing. I don't do any liquid rhinoplasties. We've got some great plastic folks in Dallas. Everyone has had something done to their face, and I just don't want to risk that. So I send them to plastics, but I love doing all the procedures that we do. So for me, I think safety, having a good treatment plan, and really optimizing someone to look like the best version of themselves. We're getting some questions here. Someone is saying Dr. Avram has perfect skin. Yes, he's
From Rahimi, he does all my work. He's just trying to get his practice in Connecticut going. That's we won't listen to him.
Someone has asked me if I use a particular system. Honestly, I personally don't. I'm very particular about my photos. I do have like an X on the ground, blue backgrounds. I'm angling the patients, and my staff kind of knows. But no, I use an iPhone. I don't think you need to invest in a big fancy phone. iPhone is wonderful. There's a question, what is the difference between fractional ultrasound, ablative fractional, and RF microblading?
Okay. Great. I'm glad you asked the question. So let me start by saying what the concept of fractional is. Fractional treatments began with Dieter Manstein and Rox Anderson. The first device came out in 2004, and the idea behind fractional is that you're treating a fraction of the skin. That's where the term fractional comes from, and then you leave surrounding tissue around it to immediately heal the skin. So you're treating, like I was saying during the lecture, 20-30% of the skin with the skin around it. It's actually amazing. So, and I mentioned this during the talk, you can vaporize or heat kill 40% of the skin, and the skin recovers 100% within a week. Now, there are different ways of doing this. Fractional photothermolysis can be a mid-infrared laser, and that's where you're putting columns of heat down and you're causing coagulation. Ablative fractional resurfacing is when you're vaporizing the skin and you're you're not heating the skin in columns, you're removing the skin in columns. You're actually using a device to literally vaporize it into thin air. And that's erbium laser 2940. That's the strongest laser that takes up water, which is very plentiful, so it's a little bit more superficial. And then you have CO2 laser that goes more deeply. Radio frequency is fractional because they use the term microblading, and what the term should be is microneedling. You put needles into the skin, and then you use typically bipolar radio frequency, and it heats. And with these needles, it heats along the needles with the conduction, and you get the needle going into the skin and the heat going down the skin with areas around it that are unaffected. And what I was saying earlier is in skin of color, you can insulate the needle so it only puts the energy in deep so that you don't affect the area where the pigment is, which is the dermal epidermal junction. Finally, fractional ultrasound. That's what I talked about in the last part of the talk. That device puts little focuses of energy at 3 different levels with areas around it that are not affected. So that there's those pinpoint areas that are targeted. So these are all different ways of treating part of the skin. But what's interesting is you're treating part of the skin to get rejuvenation of all the skin. And so that's basically the concept of fractional. And that's been the biggest change over my career over the last 15 years is the extent to which we're using fractional for just about everything now in terms of skin rejuvenation.
We had a question about Sculptra for the temples. I think Sculptra is wonderful for the temples. I also like to use other high G prime HA fillers in that area, and I think it does a wonderful job to lift the area. I think this is an area, depending on what product, it does take quite a bit of HA filler depending on the level of volume loss in that area. I would say that Sculptra is a wonderful option, but remember, patients want sometimes immediate results, and with Sculptra, it's something that's going to take some time, but I think it's a great option. We had one more question. It said, aside from sunscreen, what is your best anti-aging for someone in their 20s?
I mean, again, it kind of depends what you're doing. There are lots of topicals, and we can discuss topicals. In terms of devices or treatments, it depends what you're trying to prevent. In terms of when I think of aging, I think of sun damage, and I think things that help are light fractional devices, or these devices that are lower energy. I don't want to use the name brands of them, but one's a 1927 nanometer laser, one's a mid-infrared laser. They're very popular. And those, I think, are a good way to do what we call rejuvenation, which is, and some people are using the names of some of these devices here, and they're correct. That you do what is called prejuvenation. You do a little bit of improvement now, but you're also preventing things in the future. Botulinum toxins do a great job of that, and we have patients coming in younger and younger to do that. Also, IPL devices, BBL devices, those also help in terms of helping with pigment, helping with texture and tone, and preventing some issues. So there are multiple different devices. And if you want to talk about some of the topicals other than the retinoids, by all means, do so. Sunscreen, I will say this, there are 3 things you can do to prevent sun damage when you're 20s or any age. Number 1, wear sunscreen, stay out of the sun. Number 2, use retinoids, things like Retin A or different things like that to prevent sun damage. And number 3, if you're a smoker, quit smoking.
I agree with all those points. I think also just taking good care of your skin, the appropriate skincare for your skin type. Less is more. I don't think you need these 15-step things that you're seeing on TikTok and other places. I keep my regimen very simple. A cleanser for your skin type. If you want an antioxidant in the morning, a great sunscreen, and a nice a cleanser moisturizer for the PM, and I think you're good in your 20s. But I think it's wearing photoprotective clothing, getting proper sleep and proper nutrition. I think that's one thing that we don't stress enough is your gut health and your well-being, your nutrition. I see a lot of patients for hair loss, and one of my first questions are their diets. Everyone's on these fasts and they're doing all these different very restrictive diets. You can't have healthy, beautiful skin if you're not well from within. That's always my first advice, is to take good care of yourself. We did have a wonderful question about RF microneedling, if it's safe in skin of color. And I would say absolutely yes. I think that's one of the best treatments in the right hands, because we were working through heat. And I would love to hear your opinion on that as well.
Yeah, so I'm going to say a couple things leading into that answer. Well, first of all, let's talk about microneedling, then I'll get to a larger point. Number one, it is a great technology. It's essentially fractional technology. What you're doing is you're putting the microneedling into the skin. And if you just do microneedling, I don't want to be controversial, but you're doing less than if you do that in combination with heat. When you're doing with heat, you're going to get more changes in the skin than if you're just doing the microneedling itself. And the reason it's safe in skin of color is, number one, you can adjust the settings to make it safer. But the other thing is you can actually direct the energy to bypass the area where the pigment is. So the pigment in your skin is actually very superficial. Underneath that, there aren't pigment issues. So if you get the needle beneath that, and you can do that with the fractional ultrasound and with the monopolar radio frequencies as well, and other ultrasound tightening devices, you will bypass the area where the pigment's an issue. So you can do it very in all skin types. So I think it's important. I think skin of color is something that we definitely need as a full topic on one of these Instagram live sessions, because there's so much that's misunderstood. I think we undertreat patients in terms of that due to fear. And you have to be careful of certain devices, but some devices are much safer than others, and microneedling is one of them. Having said that, to go to two broader points. Number one, what Dr. Houshmand said earlier is absolutely right. It actually really matters who's treating your skin. So if you're treating someone with a botulinum toxin to relax their forehead lines, or if you're doing filler on them, or if you're doing laser on them, it's not the device, it's not the syringe, it's the person using it. And it's true for all of those. And I can't emphasize that enough. And seeing a board certified dermatologist with experience, these devices were developed by dermatologists, and there's a special expertise in understanding the skin. It really does matter who's doing your treatments and how experienced they are and what knowledge they have. And I can tell you the devices that we use here are very powerful, and they're great when they are done appropriately. When they're done inappropriately, they're dangerous. When you do fillers, and they're actually, you can see on TikTok, kids injecting themselves. When you do fillers and you don't know what you're doing, you can get necrosis of the skin, you can get blindness, you can even get stroke. And with toxins, you can do the same. So it's all of these things. And when you see anyone saying that these things are interchangeable, they're not being honest with you. And that's going to be my final point that I'm going to make, which I think is the most important. It's a little ironic that, as it said here, it's not the device, it's the doctor. Yes, that's exactly what I'm saying. There's another thing I want to say. It's ironic I'm saying this. I'm on my own Instagram account. Don't believe what you see on social media. I can tell you, as someone who does this every day, both treating patients and being on social media, that the vast majority of what I see is either misleading, misinformed, or flat out wrong. Do not think just because someone takes an iPhone and says something that what they're saying is correct, or that it's appropriate, or that they have any of the appropriate training to do this. There is so much that is misleading. What you see on social media is only as good as the person who's giving you that information. And in this case, it's the American Society for Dermatologic Surgery. And I think you have a vetted society here. And as you have these going forward, I think it's very important that we do this, because this is good information. I can't tell you how much is just flat out wrong. And as a consumer, I know there are a lot of patients on here. I wish I could give you a more comforting message. Just be careful whose accounts you follow, and speak to someone who has the experience and the training to give you the correct information and give you the correct treatments.
I couldn't agree with you more. I think a lot of us, especially myself and Dr. Avram, I came on social media because I just was very taken aback by some of the misleading and incorrect information out there. I really do think it's important to follow credible sources. So someone asked me, I always put at the bottom of my post, see your board certified dermatologist. So what is that? Because there are a lot of things out there. If you see AAD. That means Fellow of the American Academy of Dermatology. That is a board certified dermatologist. Then how can you tell? You can go on the American Society of Derm Surgery's website or the American Academy of Dermatology's website and look us up. You can put what city you're in, anything that you want, and you can find us that way. If we're not on there, chances are who you're seeing is not really a dermatologist. And unfortunately, on social media, I want to share this. It is not illegal to call yourself a cosmetic dermatologist, a skin expert, even dermatologists. I've seen that. So really be cautious to the public out there. We really want you just to be safe and to get the best treatments possible. I think people sometimes don't know that dermatologists treat over, I think it's 3,000. We spend 1 year minimum of a internship year and 3 years of dermatology training. We take specialized boards and then there's fellowships. So really it's critical to understand who you're seeing. We have pediatric dermatology experts, cosmetic and laser experts, surgical experts, and we are dermatologic surgeons. That's one of the big things that I love to stress. I love to see children with eczema. I do skin cancer surgeries. I treat hair loss. By the way, we are the nail experts as well. So anything skin, hair, nails, surgical, dermatologists truly are the expert. And I am so grateful to Dr. Avram, the American Society of Derm Surgery, for hosting this, for joining me for our inaugural session. And we're going to have a wonderful year. I am going to ask, I know we have a lot of questions still coming in. It says there are a lot of non-medical professionals performing aesthetic, 100%. And unfortunately, there are a lot of weekend courses, there are a lot of things, and then people have a paper and say they're an expert in something. Really vet who you're seeing. This is not to put down any colleagues, but really we have people in medicine and non-medical folks that are doing these procedures. And I always say, I did go to medical school. I delivered babies when I was a medical student, but you certainly would not want to come to me to do that or to pull your teeth or do anything like that. I am in my scope of practice through my training, and I can't stress that enough. So really look for experts. There are wonderful dermatologists. Contact ASDS, contact myself, Dr. Avram. I do respond to my DMs. If you're in a particular city, if I've had people this week ask me, who's good in this city? I want to do this. I had someone that had a black tattoo in Michigan. I found someone great and sent them a name, a true board certified derm. But again, ASDS, AAD, these are great resources for you. Now, I do have to ask Dr. Avram, we're going to have more of these. Can you please nominate who you would like to see next? And guys, you can respond to who would you like to see interviewed?
Well, there's so many great people in our field. I feel like in terms of social media, I think that Dr. Sandra Lee, aka Dr. Pimple Popper, would be a great person to do the next lecture. She's such a phenomenal individual. She has so much to teach, and she's such a powerful voice. So I'd love to see if Dr. Lee do a session for ASDS next. That would be wonderful.
I love it. Okay, Dr. Sandra Lee, you're tagged. You're up next, I hope. I hope that you'll join us. Thank you both. Thank you, Dr. Avram, for such a wonderful lecture. And thank you all so much for joining us. And I'm loving we're getting some nice feedback here. But please give us, someone is nominating Dr. Doris Day. I love Doris. We would love to have Dr. Day as well. She's wonderful. And let us know what topics are of interest to you. The goal of this is to help educate the public, to help educate our colleagues. And so thank you all so much for joining us. And if there's anything or any question, oh, Dr. Shino Bay, I agree. These are all wonderful, wonderful suggestions, and we'd love to have them. You're so welcome, and everyone have a good night. Thank you. Bye, everyone.